Thank you everyone for being here today for the Myths and Facts about Sleep and Chronic Pain webinar. I'm going to go ahead and get started with a few of our technical points and introductions while some people are still joining us. This webinar is our second webinar in our new series, Chronic Pain, Improving Life While Living It, and we're very glad to have you all here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, also known as CIRPD. This webinar is co-sponsored by CIRPD and Pain BC, and we're also working in collaboration with the Canadian Pain Coalition. As I mentioned, my name is Tanya, and I'll be moderating the presentation today. We also have on the line Anne Gillespie, who's been working on organizing this webinar series, and she'll be doing the question collecting and summing them up for the question and answer portion at the end. And our presenter today is Dr. John Fleming. Dr. Fleming is a diplomat of both the American Boards of Neurology and Psychiatry and Sleep Medicine, a fellow of the Clinical Sleep Society, a fellow of the American Academy of Sleep Medicine, a distinguished fellow of the American Psychiatric Association, and a founding member of the Canadian Sleep Society. His research interests are in sleep and psychiatric disorders and the psychopharmacology of sleep and wakefulness. He's a consultant in the sleep disorders program at UBC Hospital in Vancouver and is the associate head for education in the Department of Psychiatry in UBC. We're very excited to have him here with us today, and I'm going to go ahead and hand it over to him. Thank you very much. Here you are, John.
Thank you, Tanya, and good morning to those of you who are on coastal time, and good afternoon to everybody else. I'm going to be talking about myths and facts about sleep and chronic pain. And I don't seem to be able to move to my first slide. Oh, here we go. So these are my objectives. I'm going to describe how normal sleep is generated and maintained. Then we'll talk about how pain interferes with sleep and how disturbed sleep exacerbates pain. And then discuss strategies that have been proven through research to improve sleep quality, help in reducing pain, and improve quality of life in patients with chronic pain. So this is very timely. This was a press announcement just yesterday that came out concerning a new pain research program at the National Institute of Health. I just draw your attention to the complexity of what we're about to talk about, because this is what they're looking at. Factors such as emotion, attention, genetics, and environment affect pain perception and how chronic pain in itself can induce pain changes. So it's important that we understand, first of all, what we're talking about, and there are, according to this classification by Dr. Clifford Wolf, this is a review that's available in the Journal of Clinical Investigation. It's on the public domain, so you can access it if you wish. Basically, there are three types of pain: nociceptive pain, which is largely caused by chemical factors, inflammatory pain, and then pathological pain, which is subdivided into neuropathic and dysfunctional. Dysfunctional pain is when the pain experience is experienced in an unusual way. So nociceptive pain is the common pain that we get when we crush our fingers or hit our fingers with a hammer. That's mechanical pain. Thermal, when we touch something very hot or very cold. And of course, when we're cutting onions, that's a chemical type of pain that we experience in our eyes and causes lacrimation or tearfulness. Neuropathic pain, on the other hand, is more complex. It's a chronic pain state usually accompanied by tissue injury, and nerve fibers may or may not be damaged, but they become dysfunctional in that injured state and give off signals that are interpreted as pain. And the pain that's typically described in neuropathic pain is shooting, burning, or tingling, and sometimes with numbness. Pain is extremely common. It is the most common reason that we consult physicians. It's estimated, if you look at the prevalence data, 7 million Canadians will suffer from chronic pain, and really it's very stable in Western populations. About 23% of the population will have chronic pain, which is pain experienced daily for 6 months or more. It is affected by age. 50% of community-dwelling seniors will complain of pain, and 80% of nursing home residents will complain of pain. Not only are these older people, but they usually have multiple diseases which can of themselves affect their sleep, but also their psychological adjustment. And we will be talking about the clear relationship there is between insomnia, pain, and depression later on. Important to remember that age impacts all of the illnesses that we experience. So the prevalence of most medical and psychiatric illnesses do in fact increase with age, and sleep performance and actually your resilience both decrease with age. As far as sleep is concerned, we're probably at our maximally sleep efficiency in the late teen years, and all of us abuse that. But as we then go into the 30s, 40s, 50s and so forth, our sleep performance actually changes for a variety of different reasons. It worsens with each additional illness that we get, almost in a linear relationship. So if you have rheumatoid arthritis and diabetes, you're going to have double the sleep performance burden that somebody with just a single illness might have. The medications that are used to manage illnesses can cause, either through a direct effect or through an interaction effect, can affect sleep, and I'll talk a little bit about that. So first then to sleep physiology. The most important thing to remember that sleep is part of a homeostatic drive. It's a drive of two types of drive. The first one is the process S, known as process sleep. This is a homeostatic sleep drive, and it makes common sense. The longer that you're awake, the more your sleep pressure will actually build up, as you can see with this arrow. And the important thing also to remember is as you sleep, your sleep pressure falls off. And this is where the elderly will be experiencing some of their sleep difficulties, because sleep pressure will be less during the night. They'll be more prone to have awakenings during the nighttime. And the major need for and duration of sleep is determined by the amount and quality of sleep in the preceding sleep period. The alternative opposite force that's in the sleep drive is the alertness drive, and that's a circadian rhythm. Starts to peak as we wake up in the morning, so we wake up with a fall off to basically keep the sleep drive at bay, and the time that that doesn't do it is when there's a drop off in the circadian rhythm around about lunchtime, when people will generally report being quite drowsy, and of course if you have a sleep debt, this is where you're very likely to go to sleep. The circadian drive picks up again in the evening time, just falling off before the sleep period, and it's at its lowest. This is where shift workers will usually get into trouble at 4 o'clock in the morning, because that's when your core body temperature is at its lowest, and it's also when the sleep drive, the arousal drive is at its lowest, and you may then get impending sleepiness. So these are the two factors. Process S is mediated by neurotransmitters, and there are complex interactions that go on in the brain at the sleep process. Activating neurotransmitters are histamine, which is why antihistamines make us drowsy, and noradrenaline and dopamine are other examples. The more sedating ones are serotonin in low dosages, and we also produce our own benzodiazepine or Valium-like ligand that plays a role in GABAergic neurotransmitters, which is the predominant sedative effect. And then of course our own endorphins that are increased by exercise and laughter are affecting our opioid receptors and will also be fairly sedating. Process S is mediated mostly by light, and that's why light exposure is very important, both getting adequate light but also the timing of that light. This was demonstrated by Nathalian Richmond and Kleitman. This is Kleitman here, in experiments that were done in the 50s in the Mammoth Caves in Kentucky, where there was no light signal. And what they were interested in is what happened to their sleep-wake performance. As you know, the sleep-wake rhythm, it needs to be retrained every night because it's slightly longer than 24 hours. And Richardson, who's here, he free ran, so as he went to bed, he would go to bed later and later, but Kleitman kept his rhythm fairly regular, as many people will do. But it's that fact that the rhythm can advance that will result in the problem with sleep initiation. So the most important Zeitgeber, which is from the German meaning time giver, for our circadian rhythm and keeping us entrained is light exposure and the time that we get up in the morning time. And I'll be coming back to that as part of the rules of managing sleep. Remember too that sleep is not a homogeneous state. There are 5 different physiological states that occur that stage awake. Stage 1, which is a transitional state every time we go from wakefulness into sleep. Stage 2, where we spend most of our night, and that's a quiet brain and a movable body. And stage 3 and 4, which is the deepest stage of sleep, but it's the shortest period of time, and it's the one that decreases as we get older. So that's another reason why the elderly don't have very deep sleep. And then stage REM, which is a very active stage for the brain, highly active brain, but the body is paralyzed due to what's called atonia being emitted through the pontine system in the brain. And most 80% of patients woken from dream sleep will report dream material. So this is what it looks like on the EEG. That's how we measure sleep in the sleep lab. It's not necessary to do this in all cases, but just to show you what it's like. What happens as we're awake, we get a slowing of the EEG. So in drowsy, it starts to get slower, and you get what are called alpha waves, and then specific theta waves that occur in stage 1 sleep and also occur in REM sleep. And stage 2 is characterized by specific waveforms, the sleep spindles, which are 14 cycle per second activity and appear spindle-like, hence their name. And then this marked negative complex, which is an indication of a K complex, indicating stage 2 sleep. Delta sleep is divided up into stage 3 and 4 depending on how much of an epoch of 30 seconds duration is spent in delta sleep. And if it's under a certain amount, it will be called stage 3, and if it makes up most of the epoch, it will be stage 4. So large waves, and this is when it's hardest to wake people up from. REM sleep shows an activated EEG, just somewhat similar to what we saw with stage 1, and then the characteristic rapid eye movements that give it this name. These are the eye movements measured by electrodes at the outside of the eye, and there are also phasic bursts of EMG activity, which often result in limb movements that humans have, but if you have a dog or a cat, you'll probably see them when they're sleeping having twitching movements, and that's usually when they are in REM sleep. So those are the stages of sleep, and this is the normal human sleep cycle. It's a young person because of the quantity of stage 4 sleep that we see. So this is the period of time from going to bed and so-called sleep latency, falling off to sleep, and as you see, transitioning down through stage 1 into stage 2, and then going into the first period of stage 4 sleep, continuing through stage 3 to stage 4, and then as we go through the night, this person has 5 episodes of stage 4 sleep, clearly indicating it's a young sleeper. The rapid eye movement stage lengthens as the night goes on, and so you're much more likely to wake up from a dream at the end of the night than you are at the beginning of the night. And then the other characteristic feature that we all have, but if you're a good sleeper, you won't recall them, and these are awakenings. And in this instance, they're all brief awakenings, so the sleeper would not be aware of them. You have to be awake for about 8 to 10 minutes for that to register in your brain as an actual awakening. So that's the normal sleep cycle. Remember, please, that sleep occurs when the sleep drive overcomes the arousal drive. It's a passive process. You can't work at it. It's a phenomenon that just occurs. And so the insomnia will occur when the arousal system overcomes the sleep system. So there are a variety of sleep facilitators, so if you are sleep deprived, you're much more likely to fall off to sleep because your sleep pressure is high, and that's one of the rationales for what is called sleep compression therapy that I'll talk about at the end. And then, of course, the drugs that promote sleep are all sedative drugs, again, adding to the sleep drive effect. And that's what you see here. If we were going to increase sleep drive, that could be done through drugs or through sleep deprivation. And things that promote arousal are sleep. If you oversleep, then you're not going to have a very strong sleep drive. So surprisingly, if you sleep a long period of time, you're not going to be able to sleep that well at nighttime. And then physical and psychic discomfort from any cause and stimulant drugs are the other major sleep awakeners. Now, this is a model that certainly has a lot of clinical relevance. It hasn't been actually proven, but basically it's the insomnia model. And it works on the principle that what happens is there's a precipitating event, which could, for example, given we're talking about pain, there could be a car accident and the person has significant pain from the accident interfering with sleep. But after a period of time, it's perpetuating factors that start to maintain and keep the person above the insomnia line, and the precipitating factors are fading away leaving chronic insomnia. And it's these perpetuating factors that we have to consider, and protracted rest is one of them, which isn't uncommon when people are injured for them to rest a long time. But we know that if you take very healthy young people and confine them for 48 hours to bed, you'll automatically get sleep disruptions. So protracted rest is an issue, and finding the balance between rest and activity is often very important. Compensatory sleeping, that is sleeping because you have not slept well or you're sleeping at off times through napping, or a change in your irregular sleep-wake schedule, getting up at different times, even as little as half an hour can make a difference. And using drugs or alcohol that may be driving the sleep insomnia complaint. Withdrawal and social isolation are also important factors because they are zeitgebers or time givers to our social system, and particularly a lack of physical activity, which is known to increase the stages of deep sleep. So anytime you increase your physical activity, you're going to increase the quantity of deep sleep. It may not be much in terms of minutes, but it may make a difference in your overall sleep quality. And then lastly, inadequate bright light exposure. So the common sleep busters are psychiatric disorders. The most common reason that people have disturbed sleep is a psychiatric disturbance. Any substance that's stimulating, the common one that we use is caffeine, nicotine too, and most people who are smoking now are nicotine dependent, and because of social rules can't usually get their nicotine dosages in during the daytime and will preferentially smoke at nighttime, which does interfere with sleep. Alcohol, although it's a sedative, interferes with sleep, as does the common recreational drugs. A variety of different medications can cause sleep disruption. Of the psychiatric drugs that are used, the newer antidepressants, the so-called serotonin reuptake inhibitors, or the SSRI drugs, are in higher dosages activating compounds for many people, and they can induce certain types of sleep disorders that disrupt sleep. And opioids too can cause awakenings and may cause respiratory disturbances during the nighttime that will interrupt with sleep performance. And any sleep disorder will interrupt with your sleep performance, and that of course too will lower the pain threshold. The common ones are sleep apnea, which is a respiratory sleep disorder, and the restless leg syndrome, which is where people experience restless legs at sleep onset and on awakening throughout the nighttime, interfering with going to sleep and falling back to sleep. Any medical disorder that causes discomfort and pain is likely to cause sleep disruption. This is the relationship that I wanted to really emphasize, that we know that insomnia is a risk factor for depression. If you have continuous sleep disturbance over a year, you're at increased risk for developing depression. When you are depressed just by itself, that in itself can induce what's called somatized pain, and if you already have a pain syndrome, it will actually make that worse. And so we also have this relationship between pain causing insomnia, and we know from many, many studies that chronic pain is associated with changes in mood and leading to a depressive disorder. So we have this really intricate link between insomnia, pain, and depression, which is the major focus of clinical work, which is to define where should the major intervention be. Are you going to make sure that you've got, which is usually not a problem, got reasonably good control of pain, but then the things that are left are mood and insomnia disturbances, and managing all three are required to get the best outcome. This is just to show that the pain that's associated with insomnia is not quite the same as the primary insomnia. Primary insomnia is that disorder that affects approximately a third of the population, where they don't have any other disorder causing their insomnia complaint, but they're poor sleepers and have a lot of arousal. This was the first and only study actually recently published that has looked at this difference between people with pain and primary insomnia. And what you see with, this was a study of 137 pain patients, and they showed no difference in the pattern and severity of the sleep disturbance. So they had the same type of sleep disturbance, but both groups had equally sleep-related cognitions. They were concerned about their sleep performance, and they would have arousal symptoms at night. But the primary insomnia group were much more worried, and that's what we know about this group. They tend to be anxious worriers on a 24-hour basis, but particularly that becomes more problematic in the early evening hours. And also the primary insomnia group had more dysfunctional beliefs about their sleep and their sleep needs. So they would tend to want to spend a lot of time in quiet rest, which we know is not a good idea if you're having sleep difficulties, and they'd also have a lot of cognitive arousal, have difficulty turning off their thinking of any sort at nighttime. So this was the first study that's actually shown that there is a difference between patients who have pain-related insomnia and primary insomnia. What we see clinically often, though, is patients with chronic pain who don't have a previous history of primary insomnia will start to look very much like those patients because they will have some inimical sleep habits and also some dysfunctional beliefs about their sleep. So the facts about pain and sleep, that at least 50% of patients with chronic pain will complain of poor sleep. That ranges depending on the study and the definition of poor sleep, and so it's between 70 to 80% in some studies. The major types of pain that cause sleep difficulties are back pain, headaches, and muscle aches, and many of the data are only available for the USA. 28 million Americans have sleep complaints, and this has significant economical and personal costs. So we've talked about how sleep is generated and given a bit of an introduction to how pain may be related to an insomnia complaint. And now we're going to look specifically at what actually happens with pain. So it's just another of the many stimuli that can impede the sleep drive. Just as you're falling off to sleep, you may get a call from a relative that's anxiogenic, causes you to be distressed and upset, and of course you're going to have difficulty falling back to sleep. So it's just pain is like any other stimuli that causes arousal, and it's one of many that can do that. Experimentally disrupted sleep does clearly cause somatic pain in susceptible individuals, so there are people who you can disrupt their nighttime sleep and they will get more pain complaints. Those are the famous studies done by Dr. Harvey Moldovsky in Toronto in the late 70s. And disrupted sleep will affect pain perception, so we know from sleep deprivation studies that pain perception indeed will worsen. And of course, if you're into terrorist interrogation, those of you who have seen 24 Hours will be aware that sleep deprivation is one of the major methods of torture when you want to get information. Disrupted sleep affects mood and of course your resilience and your adaptation, and those are the features of a good quality of life. So when mood's down, resilience down, and adaptation are down, then you can be sure quality of life for the sufferer is going to be down too. And there's clearly this relationship between pain intensity and sleep disturbance, which makes sense. The more intense the pain syndrome, the more likely you're going to have a sleep disturbance. And chronic pain patients with insomnia experience much greater disability than those with insomnia alone. So the experimental evidence where people look at pain in the laboratory clearly show sleep deprivation reduces the pain threshold. If you selectively deprive people, that you have them hooked up to an EEG and you don't allow them to get into stage 3 or 4 sleep, that increases muscle pain. But interestingly, as I'll show you later from the Moldovsky experiments, people who are aerobically fit have less of an effect there, so there may be a protective factor from exercise. Pain increases stage 1 sleep and it decreases delta sleep. And so these are just, if you have people in the lab, you will show, as you would expect, more arousals at nighttime, which will increase stage 1 sleep, which normally makes up 5% of the night, going up to about 10 to 15%. And when you're up in that range, most sleepers will report poor sleep. And prospective studies have shown that disrupted sleep or reduced delta sleep will worsen next day pain recordings, but that's not a uniform finding in all studies. Experimental painful stimuli cause microarousals. These are arousals that you would not be aware of. They're very brief, and so you're not able to put them into short-term memory and recall them in the morning. They will increase the fast frequencies in sleep, and so alpha-delta sleep, which is a phenomenon seen in a variety of different disease states and also in normal individuals, indicates that these patients will experience their sleep as being much lighter and reduce delta sleep as well. Acute pain, as in burn victims, does not predict next night's sleep performance, whereas chronic pain does. So there's an interesting difference between acute pain, you don't get that predictive factor that you do get with chronic pain. So in terms of this relationship between insomnia and pain. This is what we know as of now. We know that pain enhances arousal and that disrupts sleep. We know that sleep deprivation and sleep disruption increase pain sensitivity and vulnerability to pain. And we know that this sets up a vicious circle of disrupted sleep and chronic pain maintaining and augmenting each other. And so the targets for intervention then are to deal with both the sleep component as well as the pain component. So that's how pain interferes with sleep. And now we're going to talk about some strategies that have been proven to improve sleep quality, will reduce pain, and will improve quality of life in patients with chronic pain. I'm not going to spend a whole lot of time talking about medications. There are a variety of different medications that are entirely appropriate in different circumstances. I will talk a little bit about what are specifically sleep-promoting medicines. So the question that you should always have in someone who's experiencing chronic pain is the control of that pain optimized through medication, and that's what people strive to do. And then the next question is, are there drug interactions or side effects that could be worsening the sufferer's sleep? It's really important if you're a patient that you do let your primary provider know what over-the-counter medications you're taking, what herbal products you're taking, and any recreational drugs that you use, because these can add to sleepiness during the daytime or cause sleeplessness at nighttime. For example, St. John's wort, which is a herbal product commonly used in mood and anxiety disorders by people, available over the counter, is very much like an SSRI and can induce insomnia as well as induce a condition called periodic limb movements at nighttime, which can disrupt sleep. So it's really important that you disclose, if you're a patient, all of the medications that you might be using that would not otherwise be accounted for, and of course for physicians and caregivers to get that information from the patient. It's important to remember that most sleep-friendly medications can cause daytime sleepiness depending on their half-life and their potency. So you just want to make sure that if you're using sedative side effects, that you're trying drugs with sedative side effects, you're going to try and maximize that by giving that in the evening or in the nighttime. Sleep hygiene is a group of behaviors that are essential to maintaining a good sleep performance. So it's really important to be aware of sleep hygiene, and these are the essential sleep hygiene rules. If you go to any website, you'll find lots of information about sleep hygiene, but these are the rules that have been proven over and over again in order to help promote sleep. And sleep hygiene is very much like dental hygiene. If you don't floss and brush your teeth go away. If you don't practice good sleep hygiene, your sleep will go away too. The first one of these rules is that you must use an alarm to get up at the same time each day regardless of sleep performance, because you don't want to have any wandering of that time. Remember what I said earlier about the Zeitgeber and light exposure. It's really important that you use an alarm and get up at the same time each day. And this includes weekends, because your circadian pacemaker, which is in your brain, doesn't know the difference between a Saturday and a Sunday and a Monday. So that there's now good data showing that normal sleepers, it has not been done in poor sleepers, but one would expect the data to show that it would be even worse in poor sleepers, that if you sleep in for 2 hours over the weekend, you'll have poorer sleep performance on Sunday night and more fatigue and wakefulness on Monday, and fatigue will persist into Tuesday. So keeping things regular is the way to go. Regular morning to noon outdoor light exposure, generally that's when you want to get it, because that resets your circadian pacemaker. So you want to get out into bright light, which is normal winter morning light at about 10 o'clock in the morning. If you're going to rest, which is often a requirement if you're ill and if you have pain, you should do so in a comfortable chair. You should avoid horizontal rests, as I said earlier. That is a risk for disrupting sleep for two reasons. One, for some reason that we don't fully understand, protracted horizontal rest disrupts the sleep-wake cycle, and it places you at more risk of having brief naps that you may not even be aware of, so-called micro-sleeps, which are disruptive to the sleep process. Napping reduces nocturnal sleep efficiency. Sometimes, though, it's essential that you do that as part of your overall health management, and if you do, then you should use an alarm and keep it short, ideally less than 20 minutes, because otherwise it's going to cause a state that's called sleep drunkenness, where you feel actually worse after the nap than you did before it, and also if it goes longer than 20 minutes, it's certainly going to disrupt nighttime sleep performance. If you are going to nap, it should be as early in the day as possible, and ideally never later than 2 o'clock in the afternoon. So this is just to re-emphasize the thing that you can see here in blue is actually an outtake from Dr. Moldovsky's paper showing that they had a subgroup of patients, 3 subjects actually, it was a relatively small study, who ran 3 to 7 miles per day, and even though they had stage 4 sleep deprivation, they were able to manage that without getting any of the somatic complaints or fibromyalgia-like symptoms that the other subjects got. So we know that daily aerobic exercise is very important for general health and mood management. It's really very important for sleep management, and as I indicated, it increases stage 4 sleep. It can be done in shifts, so you could have 2 lots of 30 minutes or break it down into 4 lots of 15 minutes. It doesn't matter. Aerobic exercise does not require a gym subscription. It means getting out there and walking. Ideally, walking in morning light is the best way. And it affects mood, improves sleep, and there are numerous studies showing that. And in patients who are clinically depressed, not patients who are depressed and have pain, but in patients who are clinically depressed, aerobic exercise has been shown to be as effective as some antidepressants. So it's a really important component. It's really important too not to have any nocturnal time cues because you can't wake up during the nighttime and look at a clock and not have a neutral reaction. It would be that the usual reaction is frustration or distress about the fact you either haven't fallen asleep yet or that you only have 2 hours left in order to before the alarm's going to go off. So covering all time clocks, all clocks that you would see during the nighttime is really an important way of keeping arousal at bay. And if you have sleep disturbance, we know clinically that one of the things that patients tell us very commonly is that if you evaluate your sleep performance, you're likely to have a bad day. But the interesting thing too is if you have disrupted sleep, you're going to certainly underestimate your total sleep time and overestimate your your wakefulness. And the reason that you do that is if you take somebody and interrupt their sleep at nighttime, their ability to accurately predict how much time they slept deteriorates rapidly. And the other interesting thing is from a study that was done by a master's student showing that patients who slept in the lab were given, some were given misinformation about how much they slept, usually 2 hours later, 2 hours less than what they would normally sleep, and they all reported having worse days even though they'd slept their normal requirement. So if you evaluate your nighttime sleep, you're often likely to have worse daytime symptoms. So you're better off not really focusing on how much sleep you got, keeping your sleep times regular, using the alarm, getting up at the same time each and every day, and not counting the hours. Now to talk a little bit about medications. This is the key guideline paper with regard to managing chronic insomnia, whether that's associated with primary insomnia or pain. That's in the sleep literature and the references from the Journal of Clinical Sleep Medicine. Just to cover that, it's well recognized that most patients that have chronic insomnia will have comorbid. That means one or more medical or psychiatric conditions that increase the risk of them having insomnia. And that then of course, those patients have a much higher risk of having disrupted sleep at nighttime and will need some form of sleep intervention. And it's really important then to treat the comorbid condition. For example, you're not going to, as a clinician, you're not going to make any progress treating somebody with chronic pain if they also have a concurrent mood disorder. You need to aggressively treat the mood disorder, and similarly, if they have a sleep disorder, treat that as well. The current algorithm for comorbid insomnia allows for a variety of different interventions, but usually in combination. So you're using sleep hygiene techniques, which are a psychological behavioral technique, pharmacotherapy, maximizing pain control, maximizing the use of sleep medication and combinations. The major psychological behavioral treatment is what's called CBTI, or cognitive behavior therapy. And I'll come back to talking about what makes up that in a few moments. The major first-line pharmacotherapy are the benzodiazepine drugs and the benzodiazepine agonists. These are similar drugs that act at the same receptor site. These are the ones that are recommended. Temazepam because of its short half-life, its name is Restless. Triazolam because of its ultra-short half-life. It's not commonly used these days. The most commonly prescribed medication in this class is Zopiclone. Ezopiclone is the one that's available. It's an enantiomer in the United States, and we've just had Zaleplon released here in Canada. Ramelteon is a an agonist of melatonin receptors that's not available in this country, and these are the preferred first-line drugs. And if they fail, then you move on to the longer-acting benzodiazepines, and most commonly in the sleep world that would be clonazepam or lorazepam, known as Ativan. So those are when the first-line drugs don't work. Low-dose antidepressants are also sometimes used when there's a first-line drug failure, and these are the common ones that are used, and the reason that they are used is that they have a sedative side effect. In general, it's not a good idea to use a side effect as a main effect, but these are used certainly in full antidepressant dosages when patients have comorbid depression. And of these, mirtazapine or Remeron is probably more commonly used, although trazodone until recently had been the most commonly prescribed sleep-promoting agent in North America, and it's marketed as an antidepressant rather than a sleep-promoting agent. The evidence for their efficacy when they're used alone is fairly weak. The studies tend to be open-label studies as opposed to randomized controlled studies, which is a higher level of evidence. There's no specific agent within this group that's recommended or preferable to others. It's important to remember that low dosages, for example, amitriptyline 10 milligrams, should not be used to treat sleep. If you have an underlying major depression, you should use full antidepressant dosages of your antidepressant in order to get the benefit and decrease the risk of insomnia. In special populations, medications such as gabapentin and pregabalin, Lyrica, can be very useful, particularly in neuropathic pain, and those are the medications that they are sedative and sleep-friendly, so they're usually given at night and during the daytime as well. Concurrent treatment with longer-acting analgesics near bedtime may be helpful, but narcotic analgesics may disrupt sleep and may cause sleep disturbances due to respiratory sleep disorders, and that needs to be carefully evaluated. The major behavioral intervention is what's called CBTI, and this has been shown to be effective in patients with primary and secondary insomnia. The major components are working out what's the minimum requirement of sleep from a sleep diary and having that as being the assigned time in bed. What this does basically is increase sleep pressure and ensures that the person is likely to sleep much better. Stimulus control is a variant of that. It's a bit more difficult in patients with chronic pain because the requirement in stimulus control, it's called the 15 or 20-minute rule depending on how it's applied. If you're awake for longer than 15 or 20 minutes, you will get up and move to another room and do something until you're next drowsy tired. You'll go back to bed at that time, and if you fall off to sleep within 15 minutes, well and good. If you don't, you get up again and you go back to a room and do the same thing until you're drowsy tired. You always get up at the same time each day. So basically what this is doing is the same type of sleep restriction where you have a prescribed time in bed, but in stimulus control it's titrated to when you're awake. It is a very effective technique, but it's more difficult for patients who have pain disorders to complete. Sleep hygiene is essential to all of these interventions, whether they are medication or behavioral, because if you don't do good sleep hygiene, you're going to weaken any effects. And as I stated before, using an alarm, no clock watching, and no compensatory sleeping and getting exercise up. Cognitive distortions are the things, belief systems that we have about sleep. The commonest one is that we need 8 hours of sleep. That's true for some people, but it's not true for all. Sleep need is highly individualistic, and like height, it's distributed on a bell-shaped curve. There are 4 trials of CBTI that are commonly referred to, and these all have shown a very clear effect of this type of treatment intervention in promoting good sleep performance, but the effect on reducing pain is slightly variable. This is one of the more famous ones by Jack Edinger and his group. Basically what they did was they used CBTI, and this is the CBTI group, sleep hygiene alone and usual care for patients who had fibromyalgia. And what they found was with the sleep hygiene alone group that there was a subset who actually limited their time in bed without being told to do so, and that's the so-called sleep hygiene plus group. As you can see, this is wake time after sleep onset, so there's a significant reduction in sleep wakefulness In patients who were on the CBT group, this is a significant difference compared to the usual care group, who are the comparators here. But the interesting thing is it doesn't make a difference in their Montreal Pain Questionnaire scores. The only significant difference is this sleep hygiene group, that we're limiting their time in bed, and that's a significant difference compared to the usual care group. So what we oftentimes see when we're managing patients with chronic pain is an improvement in sleep performance and an improvement in quality of life, but not necessarily improvement in the pain experience. But that can come with the passage of time. So to wind up then, some facts about sleep. It's a passive and subjective process. You can't will it to happen. It's highly subjective, and like pain, it's also a subjective experience. So a person, we can measure it objectively, but that's very expensive to do. So we're usually reliant on self-reports. If you have sleep disruption, your self-report is going to be less reliable than if you don't have sleep disruption. It occurs when the sleep drive overcomes the alertness drive, so the maxim is to maximize your sleep drive, and what we do, how we do that is by setting a regular arising time, limiting time in bed, not engaging in compensatory sleeping, and minimizing the alertness drive by good pain management, good stress management, and exercise. It fluctuates in the well normal, and occasional poor nights are to be expected by everybody. That happens. It can be stress-induced and usually self-resolving in that instance, and it can be more prominent in individuals who are unwell. The actual sleep requirements fluctuate. It varies widely amongst individuals and also within the same individual, both over time and both in illness and in health. And basically speaking, the sleep requirement is that amount of sleep that you need to feel functional during the daytime. The myths about sleep: sleeping pills, these are the benzodiazepine group, are addictive. They're not addictive except in patients who are already abusing medication and have addictive problems from other medications. But they do cause both a psychological and physiological dependence, which is somewhat different. So patients who are put on sleeping pills will oftentimes report high satisfaction and maintain their regular dose. In patients, depending on the condition, the chronic pain condition, they may need to be on these medications for longer than the recommended period of time, which has been set at 2 weeks, for which there is no good empirical evidence, but stems from the days when we were using short-term barbiturates and it was known that you'd rapidly grow tolerant to those drugs. That is not the case with the newer sleep-promoting medicines. Everyone needs 8 hours. That's not true, and as I said earlier, there's a high fluctuation in terms of sleep need within an individual, but also within groups. If you don't maximize your sleep, you'll be sick longer. Well, that might be the case in an acute illness, but it's not the case in most instances with chronic illnesses. If you actually start to limit or go short on your sleep a little bit, not to the point that you're actively sleep deprived and sleepy during the daytime, you may well benefit your sleep performance at nighttime. Snooze alarms may help you greet the day. That may be true from a psychological perspective, but it's not true from a good sleep hygiene perspective, because most of the time in a snooze alarm you're getting stage 1 sleep, which is subtracting your sleep drive from the next night's sleep performance. So the cue is always to get up on the first alarm, get up and move around, and as soon as possible get out into morning light. Exercise makes all pain worse. That's not entirely true, because we know that exercise can indeed make pain much better, and the growing data for patients, for example, with fibromyalgia is that appropriate exercise done slowly can make a significant improvement in pain scores. If you are sick, you should rest more. True for the acute state, but probably not true for the chronic illness states, where we should try and maximize our sleep into the nocturnal sleep period. If you are tired, you should nap. Tiredness is a very difficult thing to assess, as is fatigue. Sleepiness is the only real indication to nap, and only if you are going to be involved in a task requiring full alertness. Generally speaking, if you nap, you're going to reduce the following night's sleep pressure, and it's not a great idea. So to conclude by summarizing, sleep and pain are intricately linked. We clearly show that there's a relationship between sleep and pain, and to that mix you also have to add depression. Optimal pain management requires optimal sleep management and vice versa. And usually you're going to be using multiple treatments, some medications to manage pain, medications to manage mood, medications to manage sleep, and using that in combination with behavioral approaches that improve activation, improve sleep management, and improve stress management. Currently, the state of the psychopharmacological art, the medications that we use, is that in the absence of clear guidance on medication choice, or what you need to do if you're a clinician is carefully document the benefits and side effects with the patient and continue that treatment until it's no longer considered necessary, and always be vigilant for an emerging clinical depression, which is particularly an issue in patients with chronic pain and chronic sleep difficulties co-occurring together. So thank you for your attention. I'd be happy to answer any questions. The euro that you see here and case is important. We'll give you a download of those slides if you wish them.
Wonderful. Thank you so much, John. That was a fantastic and informative webinar. Let's see. I think we'll go ahead and hand it over to Anne for questions.
Okay. Yeah, I think we all have a good idea about the complexity of, I'm hearing a bit of feedback. I'm not sure where that's from.
Yeah, I think it might be from Jonathan. Are you still using your headphone?
Yeah.
Okay. Odd.
I am.
Okay.
Okay, well, if it's not too disturbing to people, I'll just continue. All right, we have quite a few questions here, Jonathan, and I know you did answer questions about napping, which I think is an important issue. Somebody did ask an interesting question about Latin American cultures and some European cultures where a nap is a part of the daily routine. Is that something you have any understanding of, and how that affects? They also stay up later, I think.
Well, that comes from, it's actually in diverse cultures, Mediterranean culture as well, anywhere that it gets hot at midday, and mad dogs and Englishmen are out in the midday sun. So it is usually a good idea to get into shade. But what happens in those cultures that do take a planned nap at midday is their nocturnal sleep time is shorter. They go to bed much later or get up much earlier, or a combination of both. And the important thing, the cruel thing about napping is generally not an issue for people who don't have a sleep disturbance. It is an issue for people who have a sleep disturbance because it's in that compensatory sleeping group. It sounds as though it's going to make up for things, but it actually makes things worse.
Mm-hmm. I think, and from some of the comments, I think that is a problem when you're looking at sort of compensating one day for not sleeping well the night before, and that creates its own cycle, I'm assuming, when you're always trying to compensate.
Tough. It's really tough when you have chronic pain and you want to rest, and if you haven't slept well the night before and you're resting, sitting in a chair upright, it's very difficult to resist falling asleep, particularly if you have some degree of sleep deprivation from the night before. What is required is, as best you can, to not do that, and of course not to use stimulants to do it, either using caffeine or recreational drugs, but as much as you can, keeping yourself active. And patients who are able to do that will often report an improvement in their sleep performance at nighttime.
Mm-hmm. One of the things that is large on your strategies there is, well, is light and the effect of light, and I know it's very difficult to get rooms dark when people live in urban areas. And does light, even coming from an alarm clock, have the potential to affect sleep at night?
Probably not from an alarm clock, unless it's an unusual one. The major debate at the moment is tablets and computers, whether or not your iPad or other tablet used just prior to sleep onset may be disruptive to your circadian rhythm. As a rule, you want to avoid bright light from 6 o'clock onwards. but there are no convincing data one way or the other. One of the issues with using a computer in the bedroom is that of course is causing arousal, because usually you're not just nodding yourself off to sleep, you're either playing a game that's requiring attention or responding to email that requires attention, and that is activating. We all need a buffer of about 60 minutes in order to have the letdown response that's a requirement for falling off to sleep. So that's usually what happens with computers and light.
Okay. I'm just trying to keep up because there's a lot of questions coming in here. So Tanya, you can feel free to step in if I'm missing anything too. Let's see.
How about the one that someone asked, is it true if you sleep before 10 p.m. you have better sleep through the night?
That depends. That is an old wives' tale. The basis of it is that your deep stages of sleep occur in the first 2 hours of sleep, so that's probably the reason that got set up. If you're entrained to a regular going to bed and a rising time, it's not going to matter when that is. So what is true is that that'll be the time between 10 and midnight where you're more likely to get deeper stages of sleep. But if you are entrained, for example, to a midnight to 8 o'clock a rising time, you're going to have that occur between midnight and 2.
Mm-hmm. Something you didn't mention is food. Does that have any relationship to how we sleep? And are some foods perhaps better than others? Mm-hmm.
Well, of course, everybody I'm sure is familiar with the turkey syndrome, and that is supposed to be related to tryptophan. However, tryptophan which is a precursor to serotonin, and tryptophan loading. You need a huge amount of tryptophan, which would be at least a couple of turkeys, to get a sleep-inducing effect. And most commonly what's happening there is a combination of alcohol, being satiated, and being in the evening time that we fall off to sleep. But generally speaking, the rules about food are never go to bed hungry. It's a good idea to have relatively high glycemic foodstuffs, so it's not purified flours or high sugar content as your snack, and because that will result in a falling off of your blood sugar during the night time. And constancy is the way to go. If you benefit from having a brief snack prior to bedtime, that's probably a very good idea, but don't go to bed hungry. Conversely, don't go to bed overfilled, because the indigestion will cause you to have some reflux, and that will cause you to waken up.
Somebody had a question about oral melatonin. Is that something that's you have experience with?
Yes, the problem with oral melatonin is that if you get it in the United States, it's not controlled in any way. And if you get it in health food stores, certainly in this province, it may or may not be pharmaceutical grade. And it's really important that you get a product that is pharmaceutical grades to be sure that you actually it has melatonin in it. As it's not controlled in the States, you can buy a melatonin product that literally doesn't have any melatonin in it. So you have to be careful about the melatonin that you use. The available data are that it's really most useful for people over the age of 55 to 60, and it can help improve sleep performance. The Meltion, which is the melatonin agonist that's not available here, there are good randomized controlled trials with that medication in primary insomnia, and it certainly has shown an improvement, but that drug isn't available, and we don't know if Meltion is the same as melatonin itself. So it can be helpful. You don't need to use any higher dosage than 3 milligrams. For the elder patient in the age 55 to 60, it probably should be a slow-release melatonin, and keep to use it. If you have a product that works for you, try and maintain using the same product.
That's very good. I was also going to say, Anne, real quick, we have a lot of questions about like drugs, specific drugs and how they interact with sleep. I think what we'll do with those is collect those and maybe ask John if he would be willing to answer them by email, and then we'll post those on the blog just because they are very specific and I don't think we'll have time to get into all of them. So if you ask one of those, we'll try and get those answered by John later today.
Sounds good.
Okay. Now, for people who are struggling, because a lot of our listeners are struggling with chronic pain, do you have a sense of particular sleep hygiene strategies that are the most important, or the ones to start with?
The ones that I listed in the slides as being essential are truly essential. So the most important thing is getting up at the same time each and every day, getting some exercise, and working up to getting a minimum of 30 minutes a day. But ideally, if it's a sleep and pain-related disorder, 60 minutes a day that can be done in bouts. Minimizing, preferably eliminating, but difficult to do, compensatory sleeping. And if you are going to nap, to keep it timed and limited. Don't watch clock faces during the nighttime, and don't try and calculate how much sleep you got. It's not going to help.
Yeah, those are really valuable lessons, I think, for even people who don't have sleep disturbance.
Aye, indeed. I have old age sleep changes, and I follow those rules, and they are certainly helpful.
How are we doing for time, Tanya? Do we have time for a few more?
I think we could do at least one more.
Okay. Have you had any experience with PTSD and sleep?
Yes, indeed. PTSD is that's a talk in itself.
Okay.
Where this probably will come up with patients who have chronic pain and are listening to this webinar is that they may have been involved in an accident or in a trauma that has resulted in both bodily and psychological injury, and they can experience both emotional and physical pain. What PTSD does is it's an arousal phenomenon. It's classified as one of the anxiety disorders, so it's a 24/7 degree of arousal. Needs to be managed specifically. It's one of those comorbid conditions, and managing sleep is the same strategies are used, but there may be different medications that are used for tackling the PTSD component.
Okay. And maybe one final question we'll get in here with regard to returning to work. When people are off work for, I guess, an acute situation or returning to work, can shifts, I'm just trying to understand the question here. Is it important to consider work shifts and shift rotations, such as
yes, it's very important. So, shift workers who are going back into a moving shift are going to be having an additional stress and sleep disruptor added to their difficulties. So, I mean, as a clinical phenomenon, what we try and do clinically is to not have that, make an accommodation for shift work. That has to be done on an individual basis, and it also has to be done on a measured basis that you can demonstrate that enacting the shift is disruptive to the person's sleep performance, quality of life, and pain management.
Okay, Tanya, I think we're on the hour now.
All right, wonderful. Well, I want to thank everyone for being here and for joining us for this webinar. Just to let everyone know, there will be an evaluation link in your follow-up email. So if you have any feedback you'd like to give us, we would really appreciate that. It helps us improve our future webinars. Also, our next webinar will be in mid-September and will feature Neil Pearson, and he's going to be talking about yoga for people in pain. And this is also going to incorporate some instructive videos and be a little bit more of a series, and it looks really exciting. We are still finalizing our dates, but you can look for an email on all the specifics later this month. And we thank everyone for being here, and thank you very much to John for his great presentation and the great answers to the questions as well. And we will see you all at our next webinar. Thanks for being here.
Thanks, everyone.